Okay, we're going to get started. I know I'm not Dr. Bukkapatnam, but I'm Sharon Myers, and I'm a nurse, and I worked with Dr. Bukkapatnam or Dr. Nander for years as a heart failure nurse in some of her clinics. So she's in the cath lab, and I guess the cases were running behind, so her case started late. So she is coming. So she asked me just to fill in until she can get here. So these are Dr. Nandor's slides, which I just looked at briefly. So I'll do the best that I can with these slides, having just seen them. But ask questions as we go along. And if there's something I don't know the answer to, Dr. Nander will be here. So we'll ask her when she gets here. All right. So like I said, just ask questions as we go along, because you might have a question. Other people might want to know the answer to it also. Okay, so today we're going to talk about heart failure, and you might hear it called by all sorts of names: heart failure, congestive heart failure, diastolic heart failure, systolic heart failure, here all sorts of names, but this was the old kind of general term. And so what is heart failure to you guys? When you hear that word, what do you think of? Not doing your heart's not doing its job anymore. That's what I was going to say. It's like your heart's not working right anymore. Yeah. It's kind of a dramatic term. I wish we had like a better term for it, but
I was going to say that because when I was at Kaiser, she used to call it, the educator, whatever, she used to call it compromised.
That's a better word. Yeah, I like that. Yeah.
Sounds less weak.
Yes, yes. So heart failure is just the inability of the heart muscle, the heart system, to pump effectively enough to get blood out to the brain and the organs and the muscles and all that. It's not that blood is not getting out. It's not that you can't do a lot of the things that you want to do. It's just not as effective is what it is. And there's different levels of effectiveness, and we'll talk a little bit about that. So the heart cannot pump enough blood around the body as well as it used to be able to, basically. So heart failure can be classified in different ways. Your physician or your healthcare provider may call it different things based on how they're thinking of it. So it can be classified as to whether the left side of the heart or the right side of the heart, in terms of the pumping part of the heart, is working well. So sometimes there can be more of a problem on the right side, which causes certain symptoms, versus the left side, which causes different symptoms. So you can find out whether it's right-sided, left-sided by doing certain diagnostic tests, and we'll talk about that. I think it's in one of the slides. It can also be classified based on whether it's acute heart failure, which is heart failure that's happening right now, where heart failure has gotten worse, usually kind of suddenly, and you're having symptoms right now that are causing you distress, that your medicines need to be adjusted in one way or another in order to get it under better control. Chronic heart failure is a heart failure that just is a chronic condition. So you have it all the time. It can get worse. It can get acute, what we call acute, or worse, or it can just be kind of status quo. Heart failure can also be classified based on ejection fraction. So ejection fraction is just the amount of blood that's pumped out of the heart with each beat. So depending on what your cardiac cath shows or your echo shows, that will measure your ejection fraction. And once they get a measurement of it, then they can put in your chart and tell you what your ejection fraction is. This is an important number to know if you have heart failure with reduced ejection fraction, because that can change over time based on your medicine, your diet, your exercise. Those sorts of things can really have a positive effect on heart failure with reduced ejection fraction. So you kind of want to know, if you have heart failure and you don't know what your ejection fraction is, that's kind of an important number to ask about, because that can change over time. It's a good number for you to follow. Anybody know your ejection fraction today? Anybody? Yeah, 30. And has it changed at all over time? Unfortunately not. But But you're an example of somebody, his ejection fraction is on the lower side, but because of the way that you're taking care of yourself with your diet and your exercise and being followed closely, you're doing amazingly. You're just doing wonderfully. So yeah, it's really, really good. So I say that because no matter what your ejection fraction is, no matter what kind of heart failure you have, no matter whether you have an acute, exacerbation or have a heart failure that's acute where you have really bad symptoms, the way that you manage it can make a huge difference in how you feel, how long you live, whether or not you have to go in the hospital. So lots of hope, hope, hope around heart failure. So this just shows you kind of the difference between the two different major types of heart failure: systolic dysfunction, or also called heart failure with reduced ejection fraction, and the other kind of major classification, which is called heart failure, diastolic dysfunction, also called heart failure with preserved ejection fraction. So when you look at these pictures and you look at the systolic dysfunction or systolic heart failure with reduced ejection fraction, how does the heart muscle look different than in the normal heart muscle? Take a look. This picture is not so, there's not such a big difference in that picture, but if you look here and look at this is part of the heart muscle, and look over here and here a little bit, you can see that in the normal heart, it's not as thinned out. This picture is trying to show that the heart muscle gets a little thin and stretched out. It's not a great picture, but that's what happens in systolic heart failure. So if the heart muscle gets kind of stretched out like an old rubber band, kind of, what happens with an old rubber band that's been kind of stretched out and kept in that position for a while? What happens to it? It snaps, but your heart's not going to snap. But before it snaps, it loses its what? Elasticity, right? So it can't contract. So the heart, when it gets stretched out like that, loses its ability to really pump strongly. Okay. Now, in the other one, diastolic heart failure, or heart failure with preserved ejection fraction, this muscle has gotten thickened. You see how it's a little thicker over there in diastolic dysfunction? Can you see that? So when the heart muscle gets thicker, it can't relax in order to fill with blood. So that has to happen. If your heart can't fill with blood, then even though it's pumping well, not as much blood goes out because it couldn't relax to fill. So the heart has to relax to fill, then it has to pump strongly, both those things. So in systolic heart failure, the heart doesn't pump strongly. So it fills really well, but it doesn't contract well because it's lost its elasticity. In diastolic heart failure, the heart pumps well, but it doesn't relax to fill. So in both cases, what happens in terms of blood going out to your body? It's less, right? It's just less for two different reasons. And the treatments for these two different kinds of heart failure is different also.
And people see this when they have an echo, right?
You can see, you can get diagnosed and what kind of heart failure you have by having an echo or cardiac catheterization are the two main ways they look at it. Yes.
How much does being seriously overweight contribute to a person having
Yeah, it can cause either kinds of these heart failures. That's one I think there's a slide on here that talks about the causes of heart failure, and that's really what we want to focus on today in this lecture, because some types of heart failure are you can prevent them. So, and if you have a certain kind of heart failure, some of the things that you can do in terms of the way that you're eating and exercising and your weight, those things can help reduce some of the heart failure that you have if you have heart failure with reduced ejection fraction. So here's these are called heart disease risk factors. So these are some of the things that can cause heart failure. So smoking, alcohol, drinking alcohol, and now, the studies used to show that 1 or 2 drinks a day was okay, but now the studies are showing, and Dr. Capagoda said 20 years ago, that even a little bit of alcohol is shown to increase your risk of cardiovascular heart disease. So alcohol is in general not recommended. You should definitely talk to your physician about if it's okay for you specifically to have some alcohol. So stress, what does stress do physiologically to us? Changes, increase your blood pressure. Blood pressure all by itself is one of the significant causes of heart failure. But stress also raises our sympathetic, our circulating hormones that cause us to have inflammation on the inside lining of our cardiovascular system. And that inflammation, that chronic inflammation, is what starts the whole process of laying down plaque and developing coronary artery disease. Genetics, we can be predisposed to having heart failure. There's some kinds of heart failure that aren't caused by, high blood pressure or environmental things. We're just genetically predisposed to them. My best friend from fourth grade had a genetic cardiomyopathy. And there was, even though they knew about it, there was very little they could do about it. Of course, unhealthy foods, because of a number of reasons, they can cause you to be overweight or obese, which causes heart failure. Also, unhealthy foods, salty foods specifically, cause an increase in your blood pressure, which can cause heart failure. Unhealthy food just by itself causes that inflammatory response that I was talking about. So unhealthy foods that are high in saturated fat or cholesterol damage the inside lining of those coronary arteries and starts that whole process of developing coronary artery disease and in the long run, heart failure. Diabetes, having high blood sugars. As we get older, we're at higher risk for developing cardiovascular disease and heart failure. High cholesterol, and we talked about being overweight. And high blood pressure is not on here, but it's one of them. And there's any other causes of heart failure that you guys have heard about or can think of?
So my rowing coach had viral induced things.
Yes.
And he had a snake bite. So he had a snake bite. He had a rattlesnake bite. He ended up with heart failure.
Wow. Yeah. Toxins. Toxins is not on here, but that probably was under the toxin category. Toxins, so things like chemotherapy, radiation, you can do fine with those when you're having them, but then years later, you can develop heart failure from those types of things and toxins. And then there's also, Linda just brought up, there's viral cardiomyopathies where you get a virus of some kind, and then weeks or months or years down the road, you can develop heart failure from that. So these are the stages of heart failure. And the most important part of this slide is the first one up there that talks about at risk. So this means that you have risk factors for heart failure, but don't currently have any structural, none of those changes in the heart muscle, and you don't have any symptoms. They are considering, just if you have risk factors for heart failure, they're considering that as a stage of heart failure. That's like, so what that means is that the risk is so high, even if you have risk factors for heart failure, your chance of going down that road and having structural changes and symptoms is very high. So they're considering that already to be a stage of heart failure. So that's, if you don't have heart failure, that's where you really want to intervene now, because we're all getting older. As we get older, our risk goes up anyway. So you want to intervene. And if you have any of the risk factors that you can intervene or make a change on, now's the time to do it. So what are some of the things that put you at risk for heart failure that maybe we just talked about that you could change now, that you could intervene and decrease your risk for heart failure, developing heart failure? Keeping your blood pressure under good control. Through what? Diet, exercise, medications, following it closely, knowing what it is. It's great in here because you guys get your blood pressure taken all the time. Nice feedback all the time, isn't it?
I think you can lessen your inflammatory food.
Yeah, the things that cause an inflammatory response in that inside lining. But the big ones are what? What are the big foods, the big ones that we know cause an inflammatory state? High cholesterol, and along with that, so some things can be high in cholesterol, some things can have no cholesterol in them, but they have a lot of saturated fat. So that's what you want to look for on that label, because saturated fat is as bad or worse than having high cholesterol. So you've got to look. So some things that have no cholesterol might be, you know, highly processed bakery items, lunch meat, yes, cheese. Well, potato chips, it depends, yeah, on whether they're fried or, you know, processed heavily. You got to look at the label and look at specifically, they list saturated fat now on all labels, so you can look and see. It's best to choose things with no saturated fat. Because and sugar, you know, can contribute to an inflammatory state. Absolutely, having high blood sugars. So
I do have a question. If you're worried about, concerned about sugar, what, and you're looking at the label, unfood, what is too high?
Yeah, you should look at the carbohydrate content, which is really a reflection of the amount of sugar that's in something. And I don't know the exact number for, you know, carbohydrates, but I would say, you know, if something's got 20 or more grams of carbohydrate, you're getting up there with the carbohydrate content. But I can look that up for you.
I'm trying to learn more about sugar.
Yeah.
We've always tried to be healthy, but we're trying to cut that down.
Yeah, the sugar. Yeah. Yep, it's, yeah, that's an important piece to this all.
How much is too much?
You know, do you come when Debbie Lucas is here? She'll give you an exact answer on that one. Much better than I would, because she's a dietitian and she, yeah, good question though. Okay, so we talked about the at-risk part. Then pre-heart failure is when you have structural changes, which means if they did an echo or did a heart cath and they could see that the changes in that heart muscle have occurred. So the thickening or the thinning that I showed you on that previous slide have already occurred, but you're feeling pretty good. You're not having any symptoms, so you wouldn't even know unless somebody told you, oh, on your echo, I see this. And then the next stage of heart failure is where you have structural changes and you have symptoms of heart failure, which we'll talk about some of the symptoms, but shortness of breath, feeling tired, those sorts of things. And then advanced heart failure is called class 4 heart failure, where you're being treated for heart failure, but you're not responding to it. So it's kind of the final stage of heart failure. And this just goes through that again, stage 1, stage 2, stage 3, stage 4. So you can see in the first stage, you have no limitations of your physical activity. In stage 2, slight limitations. Stage 3, marked limitations, comfortable at rest, but you're really fatigued doing, you know, minimal activity. Your breathlessness is higher than it should be. And in stage 4, you're unable to do any physical activity without discomfort. And you may be even having symptoms at rest. So what are some of the symptoms of heart failure? Shortness of breath is listed here, and a cough. Of course, you can have shortness of breath for other reasons, right? So sometimes it gets to be a little confusing, but if you've never had shortness of breath before, I'm talking about shortness of breath, not when you're on the bikes or the treadmills and when you're exercising. You should be a little short of breath when you're exercising. But if you're getting short of breath at other times, or if you become more short of breath than usual when you're exercising, that's something to talk to your healthcare provider about to see what's going on. Swelling of your feet or ankles, you notice your shoes are fitting tighter. You can also have, this says ankles and legs. Lots of times it's just in the abdomen. So if your pants are fitting tighter, for women, breasts are more swollen, your bra may be fitting tighter. Some people just have swelling initially in their hands. So your rings, you know, this can happen if you have a salty meal. But if the swelling persists, these are things to just keep in mind and talk to your healthcare provider about. Along with the swelling is caused by fluid retention. So you can see weight gain, and it's typically sudden weight gain. So you'll gain 2 or 3 pounds overnight, or 4 to 5 pounds in a week are the kind of the numbers that we think of when we think of sudden weight gain, and or weight gain that could probably due to fluid retention and can be a sign of heart failure. And then of course, tiredness or fatigue. Another symptom that people will have is where you have difficulty laying flat at night. You try to lay flat like you normally did on one pillow, and you'll notice that you're more short of breath and you have to prop yourself up with 2 or 3 pillows, or you'll be coughing at night when you try to lie flat. Bending over. It used to be that you could bend over to tie your shoes. Now you get short of breath or winded when you bend over to tie your shoes. That's a big one that I've heard from patients that they suddenly have. Any other symptoms of heart failure that you guys know of that I haven't mentioned?
The tiredness or fatigue, is that just tired or not? Just quite sleepy, like if you're sleeping, is that
Yeah, that could, yeah, especially sleepiness sometimes with heart failure can be in part because your circulation is limited. Your oxygen delivery to your muscles and your brain is diminished, and that can cause sleepiness. Yeah, so sleepiness does go along with fatigue.
Dizziness and confusion.
Yeah, not being able, feeling kind of foggy. I know we all kind of feel foggy with our thinking sometimes, but if you notice it's persistent, and sometimes it's associated with these other symptoms, that absolutely can be a symptom of heart failure. Chest pain is another one. Chest pain can be for other reasons, of course, but once again, along with these other symptoms, if it occurs, can be a symptom. So here she's listing some things we talked about. Some of them we didn't talk about. So having a fast heart rate, because your heart is not pumping well, you're not getting enough blood and oxygen. Your heart has to work a little bit harder. It pumps a little faster because not enough blood's going out with each beat. So it pumps faster so that enough blood can get out with a lot of beats. So having a faster heart rate, different types of arrhythmias, having blue discoloration to your extremities, your hands, your feet, because you're not getting enough blood flow to certain parts of your body, having your extremities feel cold, swelling in your stomach, we talked about. Your doctor may hear different kinds of heart sounds, which can be an indication of heart failure. Lung sounds, they may hear fluid in your lungs. So these are some of the ways your healthcare provider may diagnose heart failure in you also, by listening to these things and finding them on your exam. Heart failure is diagnosed with, you can see on a chest x-ray, you can see heart enlargement, an electrocardiogram, you can see changes in the waves that can indicate that part of the muscle is enlarged. An echo is the main way that we diagnose heart failure. Blood tests, you can see certain numbers are elevated. The BNP is one of the main ones we look at when looking at heart failure and how well you're being managed in terms of heart failure. And other things like cardiac CT and MRI, and different kinds of nuclear imaging. So sometimes heart failure gets discovered when you're getting worked up for something else, and they'll just see on the x-ray that your heart's enlarged, or on an MRI that your heart's enlarged. So treatment of heart failure. The main thing when we're treating heart failure is to look at the cause, because if you're down the road and you're just treating the symptoms heart failure, but you're not treating the cause, then the symptoms are going to just continue to occur because the cause is still causing the heart failure. So for example, if your doctor knows and you know that the cause of your heart failure is mainly your high blood pressure, then you want to start right there. Get that under good control with medicine. Sometimes more than one medicine is required to treat your heart failure. I mean, to treat your blood pressure and your heart failure, but to treat your blood pressure. So most of the time you may need to be on more than one medicine to adequately treat your blood pressure. Changing the amount of sodium, you're reducing the amount of sodium in your diet, can also significantly help your blood pressure. Exercise helps your blood pressure, stress management. So all the things that you guys are doing in here. So, and if you know that the cause of your heart failure is some sort of heart arrhythmia, getting that under the best control that you can. If you know that it's from smoking, of course, stop smoking. If you know it's from being overweight, if you know it's from your diabetes, all those things. So there's a lot of things that you can do that you want to be aware of to right at the very top, stopping the cause. You can also intervene once you've stopped the cause and you know that you have certain changes in the heart muscle structure, then being on the medicines that can directly work to stop that, we call it remodeling of the heart muscle. A lot of the medicines we now have for heart failure can work on stopping that negative remodeling that's occurring, that's causing it to be stretched out or to be thickened. If we know that the heart failure is caused from blockages in your coronary arteries, then having things like angioplasty or revascularization so that those coronary arteries are opened up again. And then there's things, devices that we can use for heart failure that help the heart function better, where the cardiac resynchronization, where it allows the heart muscles, the bottom part of the heart to be in unison, and that causes a better cardiac output. So instead of the bottom part of the heart kind of beating a little bit off like that, it synchronizes it so that the bottom part's pumping together. That helps the cardiac output. ICDs, implantable cardioverter defibrillator. It's common when you have heart failure, if your ejection fraction is 30% or less, that you may have certain types of arrhythmias that can be deadly. So putting in these defibrillators that detect if you're having an arrhythmia and then can shock you out of it are important to have. That's kind of down the road a little bit. So drug treatments, there's one of the primary things that people will be on if they have heart failure are drugs called diuretics. What do diuretics do?
It helps your body to get rid of the body.
Yeah, extra fluid. Yep. And there's all different kinds. When you have heart failure, most of the time you're holding on to fluids. Part of the reason is because your kidneys are not getting perfused as well with heart failure, and it can cause some kidney damage. And even a little bit of kidney damage can affect the way that you process the water and get rid of the water. So many times you have to be on diuretics to help you get rid of the water. There's different kinds of diuretics. This lists them and they work in different ways. Sometimes you're on a couple of different diuretics, depending on what's going on. And then the other treatments especially for systolic or heart failure with reduced ejection fraction are being on ACE inhibitors. Anybody know that they're on ACE inhibitors in here? Things like lisinopril. You were on it at one time. Mm-hmm. Angiotensin receptor blockers. Those are things like losartan, valsartan, candesartan, all the things that end in sartan. Beta blockers. These are things your doctor, if you're diagnosed with heart failure, they'll put you on an ACE or an ARB, also a beta blocker. How do I go back here? Yeah. Digoxin is one of the older treatments for heart failure. And depending on if you're having a fast heart rate, they may put you on this ivabradine. So we've already talked about this, but it's good to review the factors that contribute to worsening of your heart failure. I'll start on the right side there, uncontrolled diabetes. So along with having uncontrolled, high blood pressure, anything that's uncontrolled over your medical conditions can contribute to worsening, worse prognosis and worsening of your heart failure. Check your blood work, having low sodium, having an elevated BNP, having a low blood pressure. I know we think it's good to have low blood pressure, but having significantly low blood pressure hearing sounds in your heart of a third heart sound. If you're getting frequently admitted to the hospital for heart failure, that's the sign that your heart failure is getting worse and you have a worse prognosis with that. This is a slide, it's very complicated. I was just looking at this. There's a new medication. When Dr. Bukkapatnam gets here, she can go through this slide if she wants to. But I think the main thing she was trying to show with this is there's a new treatment for heart failure that I think kind of became standard of care in 2020. It's still getting added to people's regime. They're called SGLT2 inhibitors, and they were originally used for treating type 2 diabetes. And they found that people that had heart failure that were on these SGLT2 inhibitors, their heart failure improved and they stayed out of the hospital and they had less chance of dying. So now this is standard treatment, SGLT2 inhibitors.
No, it goes on our way.
Okay, so the Fantastic Four for treatment of systolic heart failure with reduced ejection fraction are mineralocorticoid receptor antagonists. That's things like spironolactone or aldactone. ARNIs, that's things like Entresto. Any of you on Entresto? I know they'd like you to be on Entresto, but you can't tolerate it, right?
Sure.
Hmm?
Bill says he is.
You're on an Entresto, magic drug for heart failure. Even though it can cause you to feel dizzy or lightheaded at times, it's worth it. It's one of the things that can cause change in that muscle and get it back to its normal size and function. So very important drug. Beta blockers. Yeah. Go ahead. No. Typically, it's the lower blood pressure. These drugs, all the mineralocorticoid receptor antagonists, the ARNIs, the beta blockers, and the SGLT2 inhibitors, all one of the side effects of all of them are low blood pressure. So, and most people that have heart failure we try to get you on all of these. So you're going to be running really low blood pressures in order to be on these so that you can get those positive changes in your heart muscle. But in order to be on all these, you have to lots of times run around with a low blood pressure, which can cause you to feel dizzy. So if you do, though, tell your doctor, because we can do certain things, like have you take certain ones of them at bedtime so that they're peaking while you're sleeping, and during the day, they're not going to be peaking, so your blood pressure is not going to be as low and you'll be able to be functional during the daytime. Or we can split up the dose. So you're taking, instead of the full dose all at once, you're taking half in the morning, half at night. So there's all sorts of things we can do if you let us know, so that you can be on the medicines to help with that heart muscle function and reverse some of the heart failure without being so dizzy that you can't do your life.
And if it's during the waking hours, drinking a lot of water.
Well, if you have heart failure, you don't want to drink a lot of water because we're trying to get rid of the extra fluid. And drinking a lot of water can work against you, so that we have to increase some of the medicines to get rid of more of the fluid. Yeah, so talk to I don't know what your specific situation is, but definitely talk to your doctor about that. So these are the ARNIs, the valsartan, also called Entresto. These are the magic drugs. They work specifically to help reverse some of those structural changes that I showed you in the heart.
So an ARNI is different than an ARB.
So yes, so an ARB, it used to be, we just had ARBs, angiotensin receptor blockers. Those are things like losartan. And this is has and things like, it has a ARB in it, but it also has this naproxeline inhibitor. So it's a double whammy. It works in two different ways. So if you're on an Entresto, then you wouldn't also want to be on an ARB. So you want to, sometimes people get confused and they end up being on both of these because you get admitted to the hospital and they might start you on one of these ARNIs, but we're already taking things like valsartan. So that's why it's always good to bring a list of your medicines and what you're taking and go over them with your doctor, because it can get confusing. So as I said, these things can cause low blood pressure. So, and sometimes different medicines have to be adjusted. If your doctor really wants you to be on one of these ARNIs, they'll start at a very low dose. Sometimes after a couple weeks, you can kind of adjust to it. Sometimes though, they may want to reduce your other medicines so that you can be on this drug. So it takes a lot of little finagling at the beginning. This just talks about the dosing. Mainly she's trying to say that you will start on the low dose as possible, but the ultimate goal is to get you up to the highest dose possible that you can tolerate, because the higher dose of these medicines that you can be on, the greater the effect is on those structural changes in your heart. Some of the adverse effects are low blood pressure, also called hypotension. There can be changes in your kidney function. You can get an elevated potassium. So that's why when you're on these, they'll be checking your blood work more frequently in order to adjust the medicines, depending what your kidney function is looking like and what your potassium is looking like.
So is this sacubitril,
Sacubitril.
is that ever prescribed just by itself?
That sacubitril valsartan is the combo drug.
I realize that. So it's not ever just the sacubitril.
No, no.
Okay.
No, I've never seen anybody just on sacubitril. It's always sacubitril, valsartan, and this depressylene inhibitor. But you should never be on Entresto or valsartan and also be on an ACE inhibitor or an ARB, because that's like it's the same drug basically. It'd be like a double whammy. Can really hurt your kidneys doing that. The SGLT2 inhibitors have a diuretic effect. So sometimes once you're started on these, they'll back off on your diuretics. You won't have to take as much of your Lasix or your other diuretic medicines, because these in and of themselves will get rid of fluid. Lower your blood sugar in your urine. They protect your kidneys, which is so great because a lot of these medicines hurt your kidneys. So these help your kidneys. They help decrease remember I showed you the picture of the thickening of the heart muscle. They help decrease that thickening you can get of the heart muscle and improve your ability for your heart muscle to relax and fill with blood. They reduce the stiffness in your arteries. And if that stiffness is reduced, then your blood pressure is better. It improves that inside lining functioning.
So this is the Jardiance and the.
These are well, I'm going to get to that. I'll get to all the names of that. I think it's the next slide here. Here's where they work. They work in the tubules of the kidneys. So this just shows that you're eating glucose, it's coming in. Glucose is going to be in your bloodstream, and that's what causes all the bad things that happen from diabetes. But what these SGLT2 inhibitors do is they, in the proximal tubule, in the initial segment and the distal segment, the glucose gets reabsorbed. So your amount of blood sugar in your blood is lower. So then all those detrimental effects that you get from having high blood sugars are reduced. I'm going to talk about that. These are some of the names. Flozins, they all end with flozin. That's what I was trying to think of. They all end in that flozin word. And I think there's another slide that's got dagaflaw. I'm not going to try to say these. Anyway, this just shows the dosing. Typically start with a lower dose and work up based on your kidney function. Some of the side effects we already talked about that they'll be watching you for are low blood pressure, too much loss of your volume. They may need to adjust your other diuretics. Urinary tract infection is one of the more common side effects, so they'll watch for that. Symptoms of that, such as burning when you urinate, pain. So the important part of this slide is that this study showed that being on an ARNI, like Entresto, plus a beta blocker, plus a drug like a spironolactone or aldactone, plus one of these SGLT2 inhibitors, extends your survival by 8.3 years versus just being on an ACE inhibitor, which is like lisinopril and beta blocker alone. 8.3 years, that's a lot of time, isn't it? Yeah. So that's why the take-home piece of this with heart failure is, yes, you will end up being on a lot of medicines, but they all work differently and they work together to increase your long-term survival and to keep you out of the hospital. So that's why you're not just on one medicine. I know we all like to just be on one medicine that can do it all, but they all work in different places and then they work together to reduce your chance of dying and to increase your chance of living a lot more years. That's a lot of years.
But if you're doing all of this because you have heart failure, your likelihood of having to take other blood pressure medicine and other diabetes medicine is lower, right? So you wouldn't necessarily be on other stuff. For
Well,
your other conditions.
yeah, unlikely, because all of these medicines, the ARNIs, the beta blockers, the mineral corticoid drugs, they all lower your blood pressure too. And then these SGLT2 inhibitors help your blood sugar. So all these drugs affect your blood pressure and your blood sugars. So these are going to be the drugs. There's other drugs you can be on to lower blood pressure and other drugs you can be on for your diabetes, but these are the drugs they're going to put you on because these help your heart failure and your blood pressure and your diabetes. That's my
But you're probably still on Lipitor too.
Lipitor, yes. Lipitor, unfortunately, does not help all these other things. So yes, you'll still be on Lipitor. Yeah. Or another cholesterol lowering medication. Unless you can do it through your diet alone, which some people can.
So it is possible to die alone.
And some people just make so much cholesterol that they need to be on drugs. But yes, when we were doing the reversal program and over at the Med Center with Dr. Capagoda, there were, I'd say probably 50% of the patients didn't have to be on any medicines for lowering their cholesterol. Yeah. I've been bumbling through. Come on, you take over now.
I think you passed through most of it. I think
Well, you
there's
can go
only-
back. The SGLT2s, I was not so great at, but any questions you have?
Uh, I think you got through most of it. Let me, the next few parts, actually, I was right in time.
Yeah.
Because the next is interventions.
Good.
So is devices we use. Sorry, guys, I couldn't come sooner. They put my patient on for cardiac cath late. The patient needed to be taken care of before, so I had to take my time. Hopefully this talk is simpler than other talks for everybody to understand. I tried to take out a lot of the scientific jargon as much as I possibly could.
You did have that one slide, that SGLT2 slide that was.
This one here,
Keep going back. No, that was.
this one,
No,
this one.
no, go back,
More.
go back.
This is my favorite slide.
I love that slide.
Yeah,
That was great. That
this
was
is
the
my
best slide.
favorite slide.
But I think it's the slide before this.
Yeah.
Yeah, and this was not to share, but to show how much interest there's been since this event, where when you had a diagnosis of congestive heart failure, your 1-year survival in stage 4 was only 35%, whereas your 1-year survival in stage 2 or 3 was 85% before all this exploded. So since the explosion of all the studies as well as research that's been going on since 2005 and even ongoing, the longevity of people that are in stage 3 or 4 has gone up dramatically. In the past, if you had congestive heart failure, your 5-year survival was very, very poor. You wouldn't be alive. Now you're alive to complain because of these fantastic 4. Like, why do you make me sick? These drugs are no good for nothing. They make me do this. Well, you're here to complain, which is good. That means that the drugs are working. So, which means they're working. This one slide I did not want to include because somebody told me, yes, there's too much science there, but it is a very novel drug that has increased the longevity and the effectiveness of some of the medicines that we use. A lot of you are familiar with Diovan or valsartan, sartans. Anybody take sartan? Losartan, valsartan, old drug, but they revamped it and combined it with another drug, sacubitril, to make it fancy. So the effectiveness in congestive heart failure and improvement of heart function really, really got better. And we usually don't see much effect in the low doses. Recommended doses, the ejection fraction or the pump function goes up. And finally, this is the target dose where we really, really see a benefit in heart failure. These are the doses I think she talked about. These are another fancy drugs, SGLT2 inhibitors, which were created as diabetes drugs, but they really don't work good for diabetes at all.
Is that right?
Yeah, they don't. They hardly reduce the hemoglobin A1C, but their benefit is in reducing all other vascular and endothelial dysfunction. It does, actually it does include fatty liver, inflammation, to the point where it's supposed to be really good overall. This is where you stop, right?
No, one more.
Okay, there.
Definitely.
Yeah, so much for all these fancy drugs we have, but guess what? How many people actually have access to these drugs? When you buy these drugs with Medicare, with insurance, most people are stuck with about $800 per month for Entresto and Jardiance. So unless you are part of a heart failure clinic where you have pharmacist support, heart failure nurse support like Sharon, who will walk you through, find the right prices and get the cost down, it really becomes a problem. So a lot of the regular cardiologists don't know about heart failure and the new drugs available. A lot of the patients are not able to afford the drugs. A lot of patients have too many drugs because we're like, oh, you need all 4 drugs, all the fantastic 4, but they cannot handle all the 4 drugs. And a lot of these drugs cause low blood pressure, as well as kidney issues, UTIs, making patients really sick. So they're like, when I didn't take these, I felt great. Now you're poisoning me with all these drugs and saying it's going to help my heart, but I don't feel good. So it's a quality of life issue. And we really have to sit down with the patient and say, okay, what are we really going for? Are we going for a good quality of life or improving the length of your life and staying out of hospitalization? Is that your goal, to stay out of the hospitalization? Or is your goal to try to balance both? So we give little doses of drugs to try to get them to a balanced state where just the right amount of drug helps them balance out staying out of the hospital and not make them feel like they're drugged. And of course, after all of these, there are no great studies to show that the whole thing will really work and actually improve their perception of life. So this is actually a really good slide, even though it is very crowded. Our whole paradigm of treating heart failure falls under, first of all, assess whether they have heart failure, stratify them, are they in stage A, B, C, D, and how to prevent it. And then, depending on the ejection fraction, pick the drugs that are needed. So if your heart functions really under 40, you need all 4 of the fantastic 4. In those people, we try to push as much of the 4 as they possibly can tolerate without feeling drugged. If the ejection fraction is over 50, the first thing we do is keep them dry, diuretics. Then we introduce the diabetes drugs, the SGLT2. And then we may or may not even add the Entrestos and the aldactols. In case their blood pressure is high, we add it. But if not, it doesn't make that much of a difference in this day and age, no data yet, whether it will show an improvement in their longevity or quality of life. If the heart function is somewhere between the low and the high, so 40 to 50, then you start off with diuretics, give the diabetes drugs, and then you may or may not add 1 or 2 of the other components of the disease, all while working on prevention. So try to work with the diabetes, try to work with coronary artery disease, try to work with arrhythmias, make sure that they don't have other risk factors that will push them into heart failure, most important component of which, of course, is lifestyle. And Sharon, no one better than Sharon to discuss that. So have you been through that already?
Yeah, we talked about, yes, we spent a lot of time talking about how even stage 1, where you're just at risk, is considered now a heart failure classification.
Correct.
It's considered a stage,
It is a stage.
not the most important stage. but
Yeah.
Make a change.
Right. And then these are devices. So when you are on all these drugs and the heart function does not improve, when it doesn't improve over 40%, then you refer them over for special pacemakers that not only pace the person in case the person needs it, but also beats in synchrony. So there's one lead on one side of the heart, there's another lead on another side of the heart, and together they synchronize the beating. So its job is not just to sit and pace, but to synchronize the beating of the heart in addition to medications to help the heart beat stronger. So heart failure with low ejection fraction, the heart's beating like this. You give them Entresto, metoprolol, Losar, and spironolactone, it beats like this. It's supposed to beat like this. So if it's not improving in spite of maximum tolerated guideline-directed therapy, then you put in a pacemaker which has one lead on this side of the heart, one lead on this side of the heart, and together they beat in synchrony and make the heart beat better. So that's end-stage heart failure, resistant to medication, stage 3, 4, where you put in this device so that it helps the drugs work better and you don't have as many hospitalizations. So that's called CRT, or cardiovascular resynchronization therapy. And it's basically a super pacemaker that sits here with wires sitting inside the heart and around the heart to make it beat. Now, if that doesn't work and the patient's still in stage 4 heart failure, going in and out of the hospital, not responding to a lot of these drugs, they bring them to the clinic, give them IV diuretics, give them all kinds of medications, it doesn't work, then the next step is called ventricular assist devices. And these devices have a battery pack, a hose that connects to one, literally a hose, connects to 2 of the outlets and inlets of the heart, and does the work of the heart outside the body, pretty much pushing the blood because the heart's just beating like this. So this battery is pushing the blood like it's supposed to. And Dick Cheney had one prior to his heart transplant. In some cases, this is used as a bridge to transplant, meaning if you're young enough and don't have any contraindications to heart transplant, and you're not responding to drugs, you're not responding to the CRT, meaning the heart synchronization, then you put this in as an artificial heart that pumps the blood and prevents or improves the heart failure hospitalizations and outcomes. In some cases, when the person's too old or has contraindications to putting in a transplanted heart, then they put this in as a destination therapy, meaning they put it in and they keep changing the battery and making sure that the pipes are working, and it acts as your artificial heart sitting outside the heart, outside the body. Now, this is not wrought without, risks. It keeps getting clogged up. The blood has to be super thin. There's a lot of complications with this. And if this doesn't work, and if you're able to, then of course, the next step is heart transplant. So congestive heart failure, the ultimate and the last step is heart transplant. Now, I was taught by really, really old-fashioned good doctors, your heart is the best heart till it really, really says, I need help. So make it work. So I see a lot of patients who come and say, I think I was diagnosed with heart failure. Can I please have a heart transplant? And I can't tell you how many people ask me that. And what they don't know is, number one, there's not that many hearts. And when you get a heart transplant, you are trading out one disease for another. Basically, a heart transplant will last about 10 years or so, but you're on immunotherapy and you're on more medicines then than you are now. All of those medicines fight each other, have to be managed, micromanaged, be very, very careful. And you have to be carefully monitored because you don't have classic symptoms because your heart was removed, another person's deceased person's heart was put in, and it doesn't have the wires that were connected to your heart. So it doesn't tell you when you're having problems. So a heart transplant is not a trivial issue that we can just send people off to. Even if the ejection fraction is 10%, really, really low, we give you maximum medical therapy, especially the Fantastic Four, and it seems to give us longevity. So as long as you stay out of the hospital, are able to exercise, enjoy going to a restaurant, a movie, visiting family, even with an ejection fraction of 10%, there is no indication for heart transplant unless you're in and out of the hospital. In some cases, it is if you're a young person or you are at risk as you age of getting into heart failure, but not everyone. And when people get a heart transplant, they should know that the family is involved in it. It's not just that person's disease. It's the whole family has to be watchful. It's a whole social situation that needs to happen. So it's a very, very big deal. But we're grateful we have this technology. We are very grateful that it works. So that's where we are at in terms of heart failure, from the mildest to the most severe, from medicine prevention, taking care of lifestyle, medications, devices, and at the end, heart transplant. So that's where we're at. You did most of it. Thank you. Thank you. Okay. Any questions at all? Hopefully it was a little simpler. Actually, it was much more scientific till Gus came and told me, you know what, you're talking about things that are way overboard. And I really appreciate that. If you think that it's too scientific, let me know. I'll make it more understanding. I mean, the point is to make you understand. So
That was very good. Very good lecture.
thank you.
I didn't say anything. We only went to one of the classes before and not in my, it's way over my head.
I'm glad you said
I
that.
shouldn't have said anything because I don't want you to dumb it down. for-
No, because you're representing others. Others are not bold enough to tell me, so I'm glad. So sorry.
She said,
Let me just, give me the pill.
That's all she did. And he was glad that, she's telling me, well, you know, the thing you do all this, you learn. I tell them. Way too old to learn at this point.
No.
I know you're a busy person, but if you ever did have a question, I'm assuming when we time it, but could we, you know, your question, and then where's that like, you're never gonna get to it because you have so much. on your plate.
Do I never get to it? No, I always get to it. I'm pretty
I don't know,
OCD.
I don't wanna put something on your plate that, and you have so much to read.
No, so honestly, you should go through your cardiologist. And a lot of my patients they're not personally my patients, will ask Linda to reach out to me. And I will ask Linda to reach out to me.
Oh,
So it comes through her. Because I am not supposed to, and I will not touch a chart.
maybe you don't have a cardiologist.
Well, if you need a cardiologist, you should have one. So ask your primary care to refer you to one.
You need to talk last week.
Yeah, we don't know, and I mean, I'm not your doctor, so I shouldn't know. So
To me, like, in case of an event, and you needed to go to emergency, that they really need to know what you're taking.
yeah.
And always have that available to
Yeah.
EMTs or.
It's a good idea to have a list of all your medicines available, any devices that you have, especially the make of the device. So if you have a Boston versus a St. Jude Abbott versus this thing, let them know what kind of pacemaker you have, whether you have an ICD. And especially important to know if you have an ICD or not, because say you pass out and the paramedics don't know, and you're actually having an arrhythmia that the device is going to shock you for. And the device knows to do that, but the paramedics don't know you have a device. They will start CPR and actually get shocked.
You can put that on your phone.
Yeah. or carry a paper that says medicines and device or something like that. Put it on your refrigerator if somebody finds you at home, but always carry some information if you have a pacemaker or an ICD especially, so you don't want bystander shock. It's a very common phenomenon, pretty scary. So,
I'll ask a question about the stoves.
Oh. I need to buy some.
okay,
I want to get an induction stove.
okay,
Medtronic says that I can't get closer than 2 feet. to the
Yeah,
stove.
yeah.
But they, stoves are not stoves. It is, some have this size magnet. this
correct,
burner, This size. and this.
correct,
They-
correct.
And so I'm wondering, and I asked my device person, and they said, check with the manufacturer.
Yeah, no,
Check with the manufacturer.
and they
There
said
could
no.
be A vague fog, and to check with your doctor.
Yeah,
And I'm thinking I'm riding light rail with a generator overhead. If I'm riding in California in the next 5 years, I'll be riding in cars that have got these symptoms.
yeah.
Is there a way of, is there a scale out there that says?
There
Mhm.
is, and Medtronic has it. The manufacturer is Medtronic.
Mhm,
So if Medtronic says you should stay 2 feet away, you should stay 2 feet away.
yeah,
And it's not just like occasionally you travel and you get out. If you're in there and cooking, say if you're a cook in a restaurant, then there's a higher chance of you having problems because of the magnet and other stuff. You never know when it'll trigger. And that's the problem, yes.
that's the.
Yeah, and it's the size of the magnet. You're not supposed to go into Hoover Dam. You're not supposed to go to big magnets.
Yeah.
But as long as you keep at least 6 feet distance. So even if there's a magnet on top of our high-speed rail, it's at least 6 feet above your head. So that's the thing. The distance squared is the effect of that magnet. So if you're 2 feet, then it's 4 times 4. So it's 2 square. If you're 6 feet, it's 36. Reduced by 36. The effect is reduced by 36. And so it's the size of the magnet and the square of the distance. There you go. Lucky you.
They don't ever post the size of the magnets anywhere. right?
You have to ask. And
Mhm.
actually there is a website.
You can, yeah, you can, YouTube shows all of the major appliances.
And their magnetic
They
size, yeah.
rate them and they say this has got the Wolf stove with
Yes.
the biggest
Magnet.
magnets.
Yeah.
and Well water in 2 minutes. And
Correct.
it's like, well, that's all over the good, but
Yeah.
there's Dying standing there, but
Yeah, no, I would stick to gas also. Any other questions? Yes.
Dr. B, you mentioned that valsartan, I think Diovan is a
Watchman's lucky. It's just a device that reduces the need for a blood thinner. So it's not an MRI incompatible. You can get all the MRIs you want. So it's not a big deal. And it reduces your need for having a blood thinner. So if you're passed out, it won't be an issue at all. Yeah. So yeah, it's better. Any other questions?
Dr. B, you mentioned, I think that Diovan or valsartan has been revamped.
Ellison.
Wait,
Yeah.
Folsom.
Can you-
Ellison and Folsom eventually. Right now, I'm going to be Folsom, Roseville, Jane.
Oh, you're still gonna be at Roseville?
Yeah, 2 days Roseville, 2 days Folsom. And then one day I'll be at the Ellison building.
No, it was gonna still be at the same place.
It will, eventually they'll change the day to the 4th Friday. Because I'll have more time, so I won't be running late.
I better check.
No, they'll call you. They'll call you. Okay, any other questions?
can you hear me?
Heart failure is pretty simple,
Can-
or
can you
Sharon
hear me?
explained everything.
Can you hear me? Can you hear me?
Yeah.
Can you hear me?
Yes. She taught
you
me a
hear
lot
me?
about heart failure as a nurse. She
Oh,
used to
gee.
work with us till she abandoned us and went away.
Can you hear
Oh,
me?
Karen, did you have a question? Sorry.
Yeah, sorry. You mentioned
raise your
that,
hand.
Karen, do you have people in Zoom?
I
you have a question?
do, I do. Can you hear me?
we had sound coming out of the speaker.
Can you hear me?
Well, if they haven't been hearing all along, I don't have any control over that.
No, I
But
hear,
They're
I,
not coming out, you're saying. you're talking, Karen, say something, Karen.
I am,
Yeah,
I
we can't
am.
hear you,
Can
so
you
what are we
speak the
gonna
volume?
put on, Ivan?
I-
Wait a second, Karen.
Okay.
Say something now, Karen.
Can you hear me now?
Yeah.
Yes, yes.
Okay, great. And I did hear the whole presentation. Thank you very much. Dr. B, you mentioned that Diovan or Valsartan, I think it is, has been revamped. I had apparently an angioedema reaction to Diovan at one time several years ago. What is the one that's revamping of that?
Sorry, the Entresto is the revamp of Diovan. So if you had a angioedema related to Diovan or Valsartan, you cannot take Entresto.
Okay.
Yeah, there
And
are other
also-
drugs. There are other drugs coming out that are devoid of that, though.
Okay.
Yeah.
And lastly, is there any stem cell research for either heart valve issues or heart in general?
For the heart valve issues, we don't need stem cells because there's lots of stents that are being created. And those stents are really beautifully replacing any diseased valve. And they can do it through the leg instead of opening the chest. But the stem cells for the heart muscle itself, they have done small studies. The results have only been very, very, very iffy. So it's been successful in only about 10% of the people. So they're still working on that in research centers. We don't think it's at the forefront of this. There are surgeries where they wrap other muscle around it, your own muscle. There are surgeries where they put rings around the heart that make the heart synchronize better, but those are all still in experimental states.
Okay, great, thanks.
Thank you. Those are way out there.
Thanks, everybody.
Thank you very much. Thanks.